This is Jim Schnabel talking about hemodynamic and thromboembolic disease and shock. This is again from the book Pathology by Robbins and Cotran, 9th edition. We begin first with the discussion of hemodynamic elements. We talk about edema fluid accumulation, which is a consequence of osmotic pressure differences. The causes are increased hydrostatic pressure. The most common example is congestive heart failure. You get reduced plasma osmotic pressure where the albumin decreases with reduced production, and this is a manifestation caused by liver disease or protein malnutrition. There's sodium and water retention. This increases pressure and additionally decreases osmotic pressure with an example, congestive heart failure with activation of the renin-angiotensin axis. Lymphatic obstruction, which can be caused by physical obstruction such as tumor, trauma, infections, or fibrosis, is another cause of edema. Hyperemia and congestion. Hyperemia is the dilation of blood vessels. Congestion is stasis resulting from impaired outflow. Hemostasis is a process of forming a blood clot. There are four mechanisms: vasoconstriction, formation of platelet clot, fibrin deposition, and clot stabilization and resorption. The role of platelets, the function depends on glycoprotein receptors and two granule types, alpha granules. The alpha granules have an adhesion molecule called P-selectin, and dense granules contain ATP, epinephrine, serotonin, and calcium. Platelet adhesion is mediated by von Willebrand factor, which binds platelet glycoprotein 1b to expose collagen. There's a platelet conformational change, which increases surface area. Phospholipids are transferred to the surface. These bind calcium and coagulation factor complexes. The secretion phase, granules are released. These activate platelets. Thrombin G protein coupled receptor is activated, and this forms a cascade of subsequent activation. Prostaglandin thromboxane A2 is a potent aggregator. The aggregation phase, glycoprotein 2b3a allows fibrinogen binding and contraction of the platelet complex. So this is a schematic showing endothelium, the basement membrane, the site of injury here with the reflex vasoconstriction. There is the endothelium release causes vasoconstriction, and you get exposure of collagen in this model. There's a shape change, platelet adhesion, shape change, granule release. There is recruitment, and then the aggregation causes a thrombotic plug to occur with adhesion to the endothelium, von Willebrand factor being the mediator here, basement membrane exposed. There's secondary hemostasis where you get recruitment. There are tissue factors that are added in. There is a phospholipid complex expression, thrombin activation, and with the aggregation of these forms right here, release of then finally thrombosis and antithrombotic events. You get release of factors listed here, and you get additional trapped neutrophils, trapped red cells, and polymerized fibrin. So you get a clot form, and this is how you get thrombosis and arrest of the bleeding process. There are deficiencies which cause problems with this. In Glanzmann's thrombasthenia, there is the glycoprotein 2b1a complex. ADP institutes a conformational change, and this is a deficiency of this process causes Glanzmann's thrombasthenia. Bernard-Soulier syndrome is a similar situation where there's a glycoprotein 1b platelet. So these are factors which cause problems here, and then von Willebrand disease, a deficiency of this factor. So there are areas which arrest the process of thrombosis, and these are three examples, and their mechanisms are here and here and here. The coagulation cascade depends on calcium, gamma carboxylate, glutamate residues, and vitamin K. Two laboratory monitors are used as a prothrombin time, PT. This assesses the extrinsic pathway, which is factors 7, 10, 5, 2, and fibrinogen. There's also an activated partial thromboplastin time, APTT, which assesses the intrinsic pathway, which is factors 12, 11, 9, 8, 10, 5, 2, and fibrinogen. So we get, again, the clotting in the laboratory. This is the intrinsic pathway with negatively charged surface, such as glass beads. You get the cascade from 12 to 11 to 9. There's factor 8A right there. Prothrombin, the thrombin, fibrinogen, the fibrinogen clot. The extrinsic pathway is the tissue factor here, and these are the two components of the cycle. So again, we get clotting in the laboratory. These are the laboratory parameters: clotting in vivo, where there's vascular damage, exposure of the tissue factor. Again, we get 7 to 7A tissue factor here, 7 to 9, 11. There's factor 8A, thrombin to thrombin, and fibrinogen to blood clots. So deficiencies of these factors cause bleeding disorders. Thrombin is the most critical clot factor component. It is present in the common pathway. It converts fibrinogen into cross-linked fibrin, activates platelets, mediates inflammation, and converts to anticoagulant when normal endothelium is encountered. The intact endothelium inhibits coagulation and generates factors. These coagulation factors have barrier to action. These include protein C and its cofactor protein S. This complex inhibits coagulation factors 5A and 8A. A heparin-like anticoagulant stimulates antithrombin 3. So in that formulation, you have, again, inactivation. This is a heparin-like molecule here, which acts on antithrombin 3, and this factor inactivates thrombin. This is thrombin here, and you get also the tissue factor pathway inhibitor. This inactivates the tissue factor. Inhibits the tissue factor 7A complex. You can also have thrombomodulin here, thrombin binding there, and this would activate protein C. These are anticoagulant actions. This is a cofactor protein S. People can have deficiencies of these, so they get increased coagulation. Endothelial effects of intact endothelium, you can get inhibition of the clotting cascade outside of that, and inhibition of platelet aggregation here, activation of fibrinolysis. Hemolytic disorders, and these are unrelated to sudden massive bleeds. These include trauma, ruptured aneurysm, intra-organ hemorrhage. These are massive bleeds, often trauma-related. There are also mild bleeding disorders such as von Willebrand factor defects, aspirin consumption, and uremia. Major bleeding disorders without anatomic cause are called hemophilias. Von Willebrand disease gives you small hemorrhages, which are called petechia or purpuras. This is more of a matter of size of those areas. The coagulation factor defects, you can get bleeding into joints, and that's an unusual manifestation. The factors are either deficient or they have an inhibitor, and if you provide normal plasma administration, the deficiencies will be corrected. If it's an inhibitor, no amount of normal plasma can correct for that, and this is a way to distinguish between a deficiency of a factor or an inhibitor of the factor in question. Thrombosis activators include endothelial injury. These expose cofactors and receptors. They inactivate plasminogen and activate thrombin. Also, turbulence and stasis. These are flow-induced changes. They induce adhesion, pro-inflammatory factors, and they cause platelet contact with endothelium. Hypercoagulability is another issue. Factor V, Leiden, and prothrombin G202-10A variants. These are silent unless they're stressed. And homocysteine has increased amounts, and they predispose to atherogenesis. Anticoagulant deficiencies include antithrombin 3, protein C, and protein S. Heparin-induced thrombocytopenia is where you have antibodies to anticoagulant heparin administration. These are formed. Platelets are consumed to produce a prothrombotic state. Also, antiphospholipid antibody syndrome. This was once called lupus anticoagulant syndrome. There are numerous systemic manifestations. This is a misnomer. The phospholipids expose proteins which mediate thrombosis. They include thrombin and glycoprotein 1. These will give a false positive for syphilis serology, and they can accompany lupus. Thrombus fate, they can either propagate, they can mobilize, they can dissolve, they can also organize, and they can recanalize. Dissolution requires fibrinolysis. Organization and recanalization can transform into connective tissue over time. The thrombi can be venous. They can embolize the lungs, which is exacerbated by inactivity, pregnancy, and surgery. These can be fatal events, sudden fatal events. They can also be arterial, usually atherosclerosis plaques, and they can embolize from the heart, oftentimes the atrium. An embolus is a detached blood clot. It can travel to lungs, heart, and brain. These are the most critical target sites. Systemic emboli are usually from the heart. These are mural thrombi from the wall of usually the atrium. These are atherosclerotic plaques. They can also originate from heart valves and the aorta. Fat embolism can exacerbate platelet aggregation and granulocyte recruitment. These can be seen after long bone fractures, cardiopulmonary resuscitation, and burns. Air embolism is decompression sickness. This is where nitrogen will transform to gas phase in vivo. Also, these are seen with iatrogenic errors if you administer air via an IV drip. Amniotic fluid embolism can cause disseminated intravascular coagulopathy. This is a rare complication of pregnancies. It has a high fatality and activation of coagulation factors. The infarct is one sequelae. This is ischemic necrosis formed by lack of arterial supply. It is affected by vascular supply anatomy. The heart has discrete supplying arteries. The liver has dual vascular supplies. The ray of occlusion and organ vulnerability to hypoxia. Shock is reduced blood supply. This creates hypoxia. There's cardiogenic shock, hypovolemic shock, and systemic inflammation. So this is a schematic of the types of shock: cardiogenic shock, or myocardial infarction, ventricular rupture, arrhythmia, cardiac tamponade, pulmonary embolism. With the exception of myocardial infarction, these are, and dysrhythmia, the other ones are rare and dramatic events where the myocardial pump is the primary failure, i.e. cardiogenic shock. Hypovolemic is fluid loss. This can become from hemorrhage, sustained vomiting, diarrhea, burns, or trauma, where there's simply inadequate blood or plasma volume. And then shock associated with systemic inflammation occurs in systemic sepsis, whether bacterial or fungal superantigens such as toxic shock, trauma, burns, and pancreatitis, where you get a cascade of cytokines, peripheral vasodilation, pooling of blood, and endothelial activation and injury. Septic shock is a leading cause of ICU deaths. The factors include pro-inflammatory agents, which affect complement, coagulation, and cytokines. There's widespread vascular leakage, initiation of a procoagulant state, insulin resistance, hypoglycemia, acidosis, and organ failure. And shock goes through progressive severity. You can have a compensatory mechanism with metabolic processes such as tachycardia, vasoconstriction, renal conservation of fluid. These are efforts by the body to correct the insult. And that will be it for the talk. Thank you very much.